So the Crystalens, as we all know, is the only accommodative lens that's been approved by the FDA. And the original submission data and studies that have been non-industry supported studies over the last number of years have all pretty much shown that the lens provides about 1 to 1.5 diopters of an accommodative-like effect. This makes the lens a good choice for a certain subset of individuals. The lens gives patients very good quality because the optic is, of course, a monofocal optic. Even though it's only 5 millimeters in diameter, it's very rare to have patients who have difficulty with night vision with the lens. It definitely provides an increased depth of field. It is able to correct astigmatism through the Trulign lens, and it clearly reduces dependency on glasses if you're able to achieve the optimal refractive outcome. And this lens is very attractive, I think, particularly to hyperopes. If you look at a +2 or +3 hyperope who maybe not a good multifocal lens candidate for various reasons, those patients tend to be really happy with these lenses because it gives them that sense of a much more youthful vision. And I do a modest number of them. I tell all the patients, however, that they're going to need a low-power ad, usually about a 150 over-the-counter pair of glasses, which again is very attractive if you're walking around at 350. Because patients generally need these in order to read at low levels of light or a small print or to read for a prolonged period of time. So that's a shortcoming of the lens. But I think a greater shortcoming is that the refractive outcomes are less predictable. Now, why is that? Well, the lens itself, of course, is very flexible. The silicone IOL has a polyamide anchor. You've all seen the lens, of course, which allows the lens to be very stable in its position, in terms of rotation. But the hinged optic is extremely flexible. So the same mechanism, which purportedly gives us the accommodative effect, also, I think, makes the lens vulnerable to shifts in effective lens position. And these lens shifts can either be axial or equatorial. And what I mean by that is, of course, axial means the lens can either move forward or move back in its position as the capsule contracts, or it can actually be caused to toric if there's an equatorial asymmetric contraction. And this leads, obviously, to a lot of problems. Now, far and away, the most common shift, and I would say that this probably occurs in about 15% of patients, far and away, the most common shift is toward myopia. And this occurs because, I'm also having trouble with this. Let's see. There we go. This occurs because as the capsule contracts, it tends to push the lens forward. And this, of course, creates a gradual increased myopia. So it's very frustrating. You have so many patients that are dead on initially. You know, an optimal goal might be to have a patient plano in their dominant eye and maybe a -50 or -75, and they do really well. They can see their cell phone. They're very happy, and then they might come back, if you haven't seen them for a while, they may come back at 4 months or 6 months, and they're -75, -150, and they're not happy anymore. I mean, they've traded. Now they can read just great, but now they're having to wear glasses to drive. Now, when this occurs because of the contraction of the capsule. And there's one very definite find that you can see when these patients begin to develop sort of these C-folds. They're sort of curvilinear folds that occur in the capsule. And when that's very characteristic when the lens is going to be shifting forward. If you look at these, once you see these begin to form, you know the lens is going to shift. Now, if you can identify that, and if you see some small shift, let's say you're really following patients carefully, and you see them at 6 weeks or 2 months, and the capsule hasn't really become densely fibrotic yet, you can solve this by simply doing an early capsulotomy and extending the capsulotomy under the hinge. And this really works for most patients. But it means that you have to see the patients and treat them early. This is where most of us, I think, go wrong. Most of us are the habit with lenses of not expecting much refractive change at all postoperatively. So if we see a patient at 2 or 3 weeks, we're generally pretty sure that that lens is going to stay there, and we ask the patients to come back. At least I do at 6 months. But these patients, you can't do that. You need to get them back again at about 2 months and 4 months to make sure that the lenses are not shifting. If you catch this early, this is successful. However, if you catch them late, it's not. And what happens is the capsule gets so fibrotic that simply making these little slits really doesn't keep the capsule from tightening up around the lens. And then you end up having to make these quadratic cuts in the posterior capsule. The effect of this is dramatic. You can see the lens as you're working shift in its position, and it works very well. The difficulty is that unless your capsulotomy is just the right size, you can have vitreous moving forward, and none of us want that. But this is very, very effective for patients who end up having maybe a diopter of shift in their lens. Okay, whoops, and I double clutched that, I think. Let's see. Okay, I'm sorry. So I've got my lost. Now, another type of shift, and this is much more difficult, are those patients who have asymmetric contraction in the equatorial area of the lens. And what you see there is you have, instead of those curvilinear folds, you get these sort of radial folds or linear folds. And these irradiate from the area where the lens is beginning to get the haptic is beginning to buckle. And then the entire lens gets torted, and you have increased astigmatism, and that's a real problem. Now, management of this is really difficult. This doesn't occur often. This is a really great reason why we don't implant these lenses in eyes that have pseudoexfoliation, because they're really prone to this. But it happens sometimes, even when you're quite sure that you have the lens well seated. I always spin the lens around a few times. I'm quite confident that I've got the lens in the equator and that the haptics aren't in a funny position operatively, but over the course of time in a very small subset of patients, I've probably only seen about 3 or 4 of these in 12 years. But when they occur, golly, I keep doing that. When they occur, it's a quandary. You know, what does one do for this? The thing that's been recommended is that you perform a posterior capsulotomy, which basically cuts through the radial folds. And this is effective. But again, what often happens when you do the circular capsulotomy and then you cut through that band, and then you can take a look and come back a few weeks later. If it's not completely okay, you can cut through the band up here. And the lens won't slip out of position. It's not going to fall into the vitreous because those polyamide haptics are so completely anchored. But you really have bought the ranch then, because if you then are not, the patient still isn't doing well, removing that lens now is not a clean case. You know, it's not a question of if you had a case like this and you haven't done a capsulotomy, you're not going to get the polyamide haptics out very easily. What you'll end up doing is amputating these and then putting in a single piece lens, and I usually just put it in the sulcus when that's happened a few times I've had to do this. But this is recommended, but I have great concerns about doing this on a routine basis for the reasons I mentioned. What I also know doesn't work, and I've seen guys try this, is to go back and either reposition the lens or to replace it with another crystal lens. They're not going to do well. You know, once this contraction starts, the crystal lens is off the table for that lens, in my opinion. And finally, you also find hyperopic shifts, and this tends to occur when you get the capsular phimosis. And as this capsule begins to tighten up, the lens will actually move posteriorly. And of all those, capsulotomy techniques we've talked about, this is probably the least amenable to treatment. It's very difficult to get these lenses to shift forward once this has happened. But what is marginally helpful is to treat the anterior capsule, and again doing a quadratic capsulotomy. And I've seen this help some patients, but usually not enough. You know, if they're plus 150, they become a plus 1. Maybe you get a half diopter out of it, but it's hard to get much more. So just in summary, I think this capsular contraction is the main reason that we get shifts in refractive outcomes. This is something that isn't talked about very much at all, and yet any of us who've done a fair number of crystallens knows that it happens. It happens, especially the myopic shift with some regularity. So the trick here, I think, is really to follow these patients carefully and to address these problems early, and then know when to quit. So thanks very much.